about placenta in details, but before proceeding to the lecture, let's discuss the one image I have missed in the previous lecture of umbilical cord. This is difference between true knot and false knot. Here you can see true knot, and true knot are really very rare. Very rare chances true knot are formed. In this baby, you can see this true knot. Okay, and a false knot is kinking of the umbilical vessels or local collection of Watson's jelly, maybe due to that. And for knowing more about umbilical cord, do check the umbilical cord video. Okay. So proceeding to the today's video, placenta in details. Here you can see the normal position of placenta in uterus during pregnancy is in the upper uterine segment. A placenta is attached in the upper uterine segment near to the fundus. This is a fundus part and it is attached near the fundus inside the uterus, obvious. So placenta is a feto-maternal organ which is a connection between a mother and the fetus to support the fetus for transporting it acts as a transport system to transport variety of nutrients and for a respiration function. So there are varieties of function performed by the placenta. This is feto-maternal origin. So placenta is formed by basically of two components, the fetal part and maternal part. The fetal part is from the chorionic sac, which is chorion frondosum, and the maternal part is derived from the endometrium, which is a functional layer, decidua basalis. And the placenta and umbilical cords are the transport system for substances between the mother and the fetus, which is basically carried out by the vessels in the umbilical cord. And the functions of placenta: for protection of baby, nutrition of the baby, which is nutrients are transported across the umbilical vessels, and for respiration purpose, excretion purpose, and hormone production. The placenta is very important thing, you all know. Now, placenta is also known as fetal lung, is also a route by which all the nutritive material enter the fetus and fetal waste are discharged into the maternal blood via placenta. Here you can see this is a fetus within the placenta, amniotic sac all around, and chorion over that, umbilical cord of the fetus carrying blood vessels, umbilical vein, and arteries for gas exchange and a variety of purpose we have discussed. And this is full of maternal blood. Maternal blood present in the intervillous spaces. Okay, and in the intervillous spaces, maternal blood is there. Maternal arteriole and maternal venule, and these are fetal. Maternal blood is generally present in the placental villus. We'll discuss everything in detail in this video, so let's start. Placenta, human placenta. Okay, human placenta is discoid, hemochorial, and deciduate. Discoid means disc-like, hemochorial because it is in direct contact with the chorion with the maternal blood, and deciduate because of shedding off at the time of parturition. Establishes the connection to the uterine wall through umbilical cord. It is developed from the two sources we have discussed already, this like fetal chorion frondosum, maternal component is decidua basalis. When interstitial implantation is completed on the day 11th, trabecules is what? Blastocyst is surrounded on all the sides by lacunar spaces. So when the interstitial implantation is completed on the 11th day, that blastocyst is surrounded all over by the lacunar spaces, and this structure is called trabecules. So on the day 13th day after fertilization, from trabeculae they develop stem villi, and these stem villi give rise to primary, secondary, and tertiary villi further. So on the day 13, the primary villi develops itself made up of cytotrophoblast and syncytiotrophoblasts, forming a trophoblastic shell. And on the day 16, the secondary villi form, which is formed extra embryonic mesoderm inside when extra embryonic mesoderm inside enters into the that placenta, then secondary villi is known as secondary villi. On the day 21, tertiary villi form. Tertiary villi represents the fetal capillaries when fetal capillaries get into the placenta. In intervillous space, the maternal blood is there, and in the villi, the fetal blood is there. So we have three important days. day 13th, day 16th, and day 21. So on the day 13th, primary villi form, on the day 16th, secondary, and on the day 21, tertiary villi are formed. Okay. So this is a diagram. I have taken this diagram from Datta Obstetrics book. Okay. So here you can see the structure of placenta at term. So this is placenta at term, in which you can see this is umbilical cord. Okay, umbilical cord containing vessels, umbilical arteries, and this is a remnant structure, umbilical vesicle. And I have discussed this remnant part in the umbilical cord video. uh, this is a now placenta amniotic membrane, decidua parietalis and capsularis fuse to form decidua vera, uterine muscle, chorion levi. Okay. Now cytotrophoblast and syncytotrophoblast. Cytotrophoblast is an outer layer and syncytotrophoblast is an inner layer. So cytotrophoblast and syncytotrophoblast. Okay, chorionic vessels you can appreciate here. I think chorionic vessels. Okay, and intervillar space in which the maternal blood is there, and in the villi is the fetal blood is there. So this is a villi in which the fetal blood vessels are present, and this is a intervillar space in which the maternal blood is there. Decidua basalis, you can appreciate here, decidua basalis layer, and this is a decidual plate, uterine artery spiral branches. Uterine artery spiral branches is from the maternal side, and uterine vein is of maternal origin. Okay, so this is a basal plate. Basal plate is for from maternal, and chorionic plate is from fetal side. Now the fetal membranes, you can see the structure of membranes in relation to the decidua. Decidua is what? Decidua is an endometrium. Endometrium of at a time of pregnancy, it is represented or known as decidua. Okay. So fetal membranes, amnion, mesodermal layer, atrophied trophoblast, and decidua capsularis, parietalis. When it fused, it will form vera, decidua vera, and chorion levi is formed by mesodermal layer and atrophied trophoblast. So functional unit of placenta is cotyledons. Chorion frondosum and decidual basalis form the discrete placenta. I think now it's clear that placenta has two components, chorion frondosum and decidual basalis. It begins at 6th week and completed by the 12th week, and further until the end of 16th week. Both the thickness and circumference uh, increases simultaneously due to growth of chorionic villi with the expansion of intervillar spaces, but subsequently till the term increase circumferentially till term, but there is very little increase in the thickness till the 16th, end of 16th. Both the thickness and the circumference is increasing, but subsequently till the term, till the end of the pregnancy, till the 40th week of pregnancy, it increases circumferentially rather than increasing in thickness. Placenta at term is a circular disc with a diameter of 15 to 20 centimeter with a thickness 3 centimeter, and it is thin off towards the edge. It feels spongy, and it weight is 500 gram. Ratio of weight of placenta to the ratio of weight of fetus, it is weight of fetus if you are considering the weight 3 kg, then the ratio will be 1:6. Weight equals, that is weight of placenta is equal to the weight of fetus at 17th week of pregnancy. The placenta has a two surface, fetal surface and maternal surface. Fetal surface, chorionic plate. Maternal surface is a basal plate. Maternal surface is rough and spongy and divided into cotyledons. So it is a thin grayish, somewhat shaggy layer, less than 1/5 of placenta. It comprises less than 1/5 of the surface of placenta, mapped out into 15 to 20 lobes, cotyledons, which are limited by the fissure. While fetal surface is covered by the smooth and glistening amnion with umbilical cord attached at or near its center. At term, 4/5 of the surface of placenta is formed by the fetal surface. Amnion can be peeled off from the underlying chorion except at the insertion of cord. Okay. diagram showing the fetal surface and the maternal surface. This is a fetal surface and other one is a maternal surface. This amnion, smooth glistening surface, you can see, appreciate here I think. And chorionic plate, this is a basal plate, dull red, rough and spongy and limited by the fissures. And cotyledons, lobes, various lobes you can see here. Okay, so margin. Peripheral margin of placenta is limited by the fused basal and chorionic plates with and continuous with the chorion, levi and amnion. Placenta is a specialized part of chorion. This is very important line. Placenta is specialized part of chorion, which is very special because it is a support system for a fetus, for the growing fetus. Its attachment is to the upper part of the body of uterus, encroaching to the fundus. An effective attachment due to the anchoring villi. Separation after birth of baby. The line of separation is through the decidual spongiosum. This line is important, and this is asked in various exams, like where is the line of separation of placenta is present. It is present through the decidual spongiosum. Hofbauer cells is present in placenta. So let's discuss these cells. These are present in placenta. Histological characteristics of placenta. Zika virus infect the Hofbauer cells of placenta. Okay, this is important and high yielding point. And Zika virus infect the Hofbauer cells of placenta. Now, in the fallopian tube, there are special cells known as PEG cells, and in the cytotrophoblast, special cells are Langerhans cells. Now the fetal membrane. Fetal membrane, amnion, chorion, yolk sac and allantois. Amnion is formed by the day 10th of fertilization and chorion is formed previous to it, the 8th of fertilization from the cytotrophoblast. So chorion is from cytotrophoblast. Mainly syncytotrophoblast is for hormone synthesis, while cytotrophoblast is forming chorion layer on the day 8 after fertilization, and amnion is formed day 10th of fertilization, derived from ectoderm, innermost fetal membrane. So amnion day 10th of fertilization is the innermost fetal membrane and it is having a maximum tensile strength. And the other one is yolk sac, another fetal membrane is allantois. Now the placental circulation. So on the day 15, the uteroplacental circulation is formed. On the day 17, the fetoplacental circulation is formed. Fetoplacental circulation started from day 17. In between the day 21, it is established by day 21. So it is starting from day 17 to the day 21, the fetoplacental circulation is formed, and uteroplacental by the day 15th. Uteroplacental, the maternal blood is present within the intraovular spaces. So it is present in the intervallar space with the number of spiral arteries 120 number, and oxygen saturation is there 65 to 75%. And in the fetoplacental circulation established by day 21, and fetoplacental blood flow at term is 400 ml per minute. So fetoplacental blood flow at term is 400 ml per minute. Uteroplacental blood flow at term is 450 to 650 ml. That means the uteroplacental blood flow is more than that of the fetoplacental blood flow. It is fetoplacental is just 400, while the uteroplacental is 450 to 650. Uterine blood flow at term. Uterine, okay, note the word uterine blood flow at term is 750 ml per minute. Maximum and more than the other two discussed. Rate of oxygen delivery to the fetus is equal to 8 ml per kg per minute. Uterine transplantation immunity is due to three things. First, the decidual stromal cells, inefficient decidual natural killer cells which is of maternal origin, and invasive trophoblasts that populate the decidua. Okay, invasive trophoblasts from the fetal origin. Okay, so these three things. Now this is a diagram of stem villi showing connections of chorionic plate with the basal plate. Here this is the outer part of the placenta, that is a maternal side in which maternal blood vessels is there, and outer cytotrophoblast, syncytotrophoblast is there, intervillar space in which maternal blood is there, and mesodermal core with capillaries. This is fetal origin and chorionic plate on the fetal side. So this is a fetal side and other one the maternal side. And you can appreciate more clearly here that syncytial trophoblast is present, and then cytotrophoblast and mesodermal core, and then villus capillaries. So schematic diagram to show the development of the villus, primary, secondary, and a tertiary one. I have uh, show you earlier that primary is formed. Okay, primary is formed on the day 13th of fertilization, made up of cyto and syncytial trophoblast. So this is a day 13th of fertilization. Then day 16th, in which the mesodermal core arises, and day 21, in which the villus capillaries, that is fetal capillaries, get into the placenta. So placental barrier, also called as placental membrane, it is a partition between fetal and the maternal circulation. It is not a perfect barrier because it allows certain substances to pass into. In early pregnancy, it consists of syncytial trophoblast from the maternal side, cytotrophoblast, then the basement membrane, then stromal tissues, and then endothelium of fetal capillary wall with its basement membrane. So placental barrier, it separates the fetal from the maternal blood and it prevents a mixing of them, but it is not a true barrier. So slight mixing is there. You can observe, and doctors have observed this, like fetal cells RBCs are found in maternal blood, and maternal RBCs are also found in the fetal blood, and this is known as fetal-maternal hemorrhage. Sometimes fetal-maternal hemorrhage, and in Rh negative pregnancy, this is a very serious cause for maybe death of the fetus. It is an incomplete barrier as it only prevents large molecules to pass, okay, like heparin and bacteria, but cannot prevent the passage of some viruses, rubella, microorganism, toxoplasma, trypanosoma pallidum causing syphilis, and some drugs and hormones. This torch infection can be there in the fetus because it does not. It allows the torch infection viruses and the organism to pass into the fetal circulation. Okay, now the definitive placenta, maternal and fetal side. This diagram is very important. This is myometrium and endometrium having uterine glands. Uterine glands have non-ciliated columnar epithelium discussed in the previous video. Uterine glands is having, well, overall over the whole endometrium, ciliated columnar epithelium is there. This is known as basal plate. So maternal side and chorionic plate. This is fetal side and intervillous space in which the maternal blood is present. So blood vessels is there from the maternal side. This is outer syncytial trophoblast known as Nitterbusch layer and the cytotrophoblast. Inner syncytial trophoblast, Rohr's fibrinoid strata. So remember these two terms, Nitterbusch layer and Rohr's fibrinoid strata. Nitterbusch is outer layer and Rohr's is inner layer. Now in the intervillous space, you can appreciate maternal blood in the intervillous space. These are villi. In the villi, the fetal blood is present within the fetal arteries and umbilical arteries and umbilical veins. This is syncytial trophoblast. On the fetal side, cytotrophoblast, Langhans layer. This is known as Langhans layer. Langhans cells are present here. And primary mesodome with a fetal blood vessel. This is amnion overall on the fetal side. Okay. It is about 0.025 mm thick. Near term, there is attenuation of the syncytial layer. So, sparse cytotrophoblast and distended fetal capillaries fill the villus. Clinical importance is there of this line. The thick syncytial trophoblast synthesis area and thin syncytial trophoblast is known as transfer area. I can show you the diagram here. This diagram showing some thin areas and some thick areas. Thin areas are mainly for gaseous exchange, what known as transfer area, and thick area of syncytial trophoblast is for hormonal synthesis. In the early months, Both are in equal ratios, and there is no thin and no thick areas are there, but near term this happens. Okay, so there is attenuation of syncytial layer, sparse, sparse cytotrophoblast, and distended fetal capillaries fill villus. Clinical importance: thick is for known as beta zones and for hormone synthesis, while the thin areas for the gas exchange 0.002 mm. Increase in the thickness of villus membrane is seen in the cases of IUGR and cigarette smokers. This is also a diagram taken from the placental barrier, maternal blood, syncytial trophoblast, cytotrophoblast, connective tissue, and fetal blood vessels. This is a placental barrier. Okay, basement membrane. You can see basement membrane and endothelium and basement membrane over the fetal side. Just learn this diagram by heart. This is very important diagram, especially this point. I have marked question mark. They're a very important point. Now decidual basalis and decidual capsularis. Decidual basalis is a site where the future placenta will be formed and forms at maternal site, and decidual capsularis is between uterine cavity and blastocyst. Opposite to it, decidual basalis present. Okay, so you can appreciate your decidual basalis. This is a site where the future placenta, site of future placenta, okay, on the maternal side, and decidua capsularis between blastocyst and the uterine cavity. So here is uterine cavity. This is uterine cavity, and this is a blastocyst, and in between the chorionic cavity, decidua capsularis is there. Okay, and between uterine cavity and blastocyst, decidua capsularis is there, which is opposite to it, decidua basalis is there. So this is decidua capsularis, and opposite to it, decidua basalis is there. This is at the end of 8th week and the end of 10th week. And this is at the end of 12th week. Blastocyst gives rise to embryo, which gives rise to fetus. Embryo can be differentiated as a human embryo at 8th week, and at the end of 12th week the capsularis and the parietallis layer fuse to form decidua vera. Now trophoblast on 8th day after fertilization divide into cytotrophoblast and a syncytiotrophoblast. Okay, cytotrophoblast and the syncytiotrophoblast. And syncytotrophoblast having one function, hormone factory, so it synthesizes hormone, while cytotrophoblast is near the decidua basalis, forms a villi-like structure, further forming the chorion frondosum, and it also prevents the PIH by trophoblastic invasion. Rest remains smooth, forming the chorion. Levy forms the chorion, overall chorion. Trophoblastic invasion converts maternal arteries from high to low resistant vessels occur in the two phases, first at a 12th week, then at a 16th week, and this point is very important. If trophoblastic invasion is not there, or it is incomplete, it can lead to PIH. We'll discuss PIH in the more videos. I will make videos on PIH also. There we will discuss more in details about that. But it converts trophoblastic invasion important. If trophoblastic invasion is not there or it is incomplete, PIH can proceed. PIH can be there, and this maintains the uteroplacental blood flow. So trophoblastic invasion is important to maintain the uteroplacental blood flow. I think let's discuss the anomalies of placenta in the next video along with the hormones of placenta. Otherwise, it will be too long, okay, and you will all get bored. So, let's take another video for that. Thank you.